Okay, it's 12:01, so we will begin. So good afternoon, everyone, and thank you so much for joining our virtual STEGH Talk session. Just a few quick things to note before we begin. So in an aim to reduce background noise, we're going to be muting everyone except myself and Dr. Tzemos. If you have any questions during the presentation, please type them in the chat field and they'll be answered during the Q&A portion of this presentation. And just to note, this session will be recorded and shared at a later date on our Facebook page and YouTube channel. So on behalf of the STEGH Foundation and the hospital, we welcome and thank you for joining today's special STEGH Talks virtual session during Heart Month on Cardiology. It is my pleasure to introduce Dr. Niko Tzemos, Professor of Medicine at the University of Western Ontario and Director of Advanced Cardiac Imaging at London Health Sciences Centre. Dr. Tzemos is cross-credentialed with STEGH's Diagnostic Imaging Department, is the lead of the Echo Department, and the architect behind STEGH's Chest Pain Clinic. Dr. Tzemos completed his undergraduate training at the University of Milan, graduating with a first-class honors degree in medicine and surgery. He subsequently trained in internal medicine at the University of Nottingham. After, Dr. Tzemos went on to complete 2 years of clinical research at the University of Dundee, which led to the award of Doctor of Medicine with honors in Hypertension and Vascular Biology. Early in his postgraduate training, he developed an interest in advanced cardiac imaging, subsequently pursuing further subspecialty training in echocardiology at the University Health Network Toronto, and cardiac MRI, CT, and PET with the Brigham and Women's Hospital in Boston. Dr. Tzemos completed his postgraduate and clinical training in cardiology at the University of Edinburgh, where he held the position of clinical lecturer. Dr. Tzemos' main interest is in cardiac research using advanced cardiac imaging techniques as a means of connecting basic science to clinical outcomes. Thanks so much for joining us today, Dr. Tzemos. Take it away.
Thank you very much, and good afternoon to everybody. It's truly a great pleasure to be here, and thanks for inviting me to give a talk. I think this is the cardiac month, and it's a good idea to discuss not about our own endeavors within STEGH, but also as why we have been motivated to create a service of that kind. So for the purpose of the talk today, I'm going to focus mostly on the pertinent and cardiac investigations of patients with suspected coronary artery disease. I would like to start by saying, however, that coronary artery disease, no matter how much we try, still remains #1 cause of death in North America and perhaps in Northern Europe too. This is a huge difference in comparison to cancer, accidents, and of course, it's a proportional change based on age. Now, this is due to the agglomeration, whether you take it singularly of risk factors, or you take them in association, and we'll come back to that, like family history, older age, male gender, high cholesterol, hypertension, and so forth. What's really important to note here is that there is a synergistic interaction between the traditional risk factors, as I have mentioned to you, that is of the gender, high cholesterol, and high blood pressure, to the point whereby, let us say, an unfortunate male with diabetes and high blood pressure will carry about 44% risk of developing coronary artery disease in the 5 years from the time of assessment. That has a huge implication, which begs us to understand as to why the agglomerate of risk factors may lead to high incidence of coronary artery disease. When I was in medical school, regrettably many years ago, because that testifies my age, we were told about the atherosclerosis timeline. In other words, the hardening of the heart arteries. I'm going to spend about 30 seconds to orient you on that because it's an important slide. So if you can see the first decade to your left-hand side of the screen, everything starts with what's called the foam cells, and then moving to the second, third decade, there is slowly some thickening of the wall to the point of the fourth decade, where nasty things are happening, mostly in terms of thickening of the arteries, and therefore moving to more advanced atherosclerotic changes. Please note, this is the fourth decade. This is the classical kind of notion of atherosclerosis timeline. Actually, it's not true. This is the Bogalusa heart study. It's a very, very important study. It's a study whereby done in the Bogalusa city, it's in northern United States, whereby it's a very stable population. It's not a fantastic deal. For all those unfortunate people dying, they will obtain a post-mortem. And they look specifically for early changes of atherosclerosis. If you can see in the aorta, for example, this is a pathology study. At the age of 26, 39 years old, mostly they died actually of accidents. About half of them, they have had early atherosclerotic changes, which we were told were happening on the third and fourth decade. But what's really staggering over here is that for those patients that were in the 30s, nearly 70% of them, they have had evidence of advanced atherosclerotic changes. And these are healthy people, or presumably healthy people. What I'm trying to say, we have a galopant atherosclerotic process that's decimating our population, and we will see how that really affects and what we should be doing about it. Although I have given you very bleak results thus far, we have to say the good news as well, that the risk of death secondary to heart disease is reducing. So these kind of data go back to 1900 and now to 2010. As you can see, whilst we're going through the process of industrialization, the risk of death was increasing, but now is decreasing. This is very important and curious. So why then the death from coronary artery disease does reduce? Well, because we have very, very good medications. For example, the statins, those are medications to reduce the cholesterol, not only do reduce the cholesterol, but they truly clean up the arteries in terms of removing, if not replacing, the atherosclerotic cap or the atherosclerotic changes. And that in itself may well reduce the risk of death from coronary artery disease. But this is not the whole story. If indeed the risk of death reduces, one would expect that the prevalence, in other words, the number of cases of coronary artery disease should be reducing too. These are Canadian data. So as we can see to the left-hand side of your screen, the upper part indicates the prevalence of coronary artery disease starting in 2000 up to 2012. But what we can see, we can see an increase rather than a decrease. So starting perhaps at 8% and reaching about 11 to 12%. So it's going up, which is curious. On the other count, if you go below to your diagram, and this is the more thicker line, if you wish, this is the heart failure and remains stable. And this is the same for both genders. So in other words, the number of cases of coronary artery disease increases. However, the lethal cases of consequence of atherosclerosis remain fairly stable. But why that is happening? Again, because we have tremendously effective medications in reducing the risk, or reducing not only the risk of dying, but also the risk of progressing of heart failure. For example, reducing the blood pressure to very strict criteria reduces the risk of heart failure by 37%. That's staggering. That's a very high number. And also the risk of dying from coronary artery disease by 33%. This is astonishingly high, but it does not reduce the prevalence. In other words, the newer cases of coronary artery disease presenting. And this has important implications for the Canadian population, because we would expect that the last decade, the last 2 decades, we might have reduced the new number of myocardial infarction presenting, but that's not the case. Actually, there has been a significant increase of the above, nearly about 30 to 40%, perhaps even 67%, as this slide indicates. So here we have a shortfall. We are very good in reducing the effect of the disease once is manifested, but we have ignored the fact that the disease comes perhaps earlier and newer cases are developing. So there is clearly a gap over here, and this gap has to be identified. Well, it has to do simply that we are dealing only with what we can see. In other words, with the consequences of atherosclerosis, that is of stroke, of myocardial infarction, stroke, and other changes on the arteries. But we have missed all this big iceberg that lies underneath the surface. And that's the one we haven't been very good. And perhaps that is the one that leads us to the increase of numbers of coronary artery disease. We are good in improving our quality of life, but not reducing the risks. And this has important implications because although we are able to deal with myocardial infarction, we cannot stop sudden cardiac death. This is devastating for the families, devastating for the population, for our health system. These are the data over the last 2 decades, showing that in men below the age of 50, nearly representing with sudden cardiac death, so died at home, for example, in their sleep, most likely, 1/3 of them, 35 on autopsy, had significant coronary artery disease, which had not been addressed. If had been addressed, clearly would not have been the effect, as I have shown you, with our ability of reducing the risk of death. So we need to do something about it, because if we go back to our atherosclerosis timeline, what we see is that we are dealing pretty okay with the end spectrum of the disease, that is myocardial infarction, angina, and so forth. But perhaps we haven't been that good to deal with the earlier manifestation. And this is a huge burden to us and a huge responsibility if we were to reduce the number of cases presenting. One of the first manifestations of underlying obstructive coronary artery disease, and we're going to see some very nice example with cardiac imaging, is chest pain. This is the first manifestation. But based on its symptom, it's very, very hard to discern whether it's cardiac and non-cardiac. Because if it's cardiac, then we should be doing about it. And we have seen that if we start therapy early, we're able to reduce the risk of dying. If it's not cardiac, although it leads to some degree of morbidity, in other words, admission to the hospital, yet again does not pose a risk to the patient of dying. So if the first manifestation of coronary artery disease, usually that it is, which is chest pain, is present, how do we define or what do we do with this kind of chest pain when the patient, usually what it happens, is severe enough to come to the emergency department? Unfortunately, this is poorly defined, especially in Canada and particularly in Ontario. It's well seen in the US because it's a financially driven process. However, in Canada, it's not very well defined, but has important implications. Aside of the aspect of the population, has important financial implications for our clinical resources. For example, in a busy emergency department, may represent even up to 20% of the overall admission per day. This is a staggering high number because all those patients, they need to be risk stratified. In other words, we need to identify whether truly have cardiac chest pain or they do have something else unrelated to the above, therefore clearly do not need the necessary attention. So given the lack of data, there is just a generalized outcome study from Ontario, but takes most of the emergency departments and kind of agglomerate. And if you extrapolate the number of patients for all those patients that enter the emergency department with chest pain, we see that about 1/3 of them had risk factors. Now it's becoming really apparent that more risk factors together increases the likelihood of underlying coronary artery disease. And nearly half of them have had high blood pressure. These are the data about 500,000 of the population admitted to the emergency department within Ontario, but not necessarily only with chest pain. So it's just like an extrapolated kind of population from a more general study. But we're lucky enough. These days, the technology is so advanced that we have a huge armamentarium of tools directed to investigate those patients, or in other words, risk stratify, in other words, finding whether they do have coronary artery disease. We do have CT, MRI, CT, PET, stress, and I'm going today, for the purpose of the presentation, discuss what's really available in STEGH and how can we utilize and present why we use those kinds of tests. Broadly speaking, and this is an important notion I would like to pass to the audience, is that any kind of risk stratification test is divided in what's called an anatomical test, whereby we look directly within the anatomy of the coronary arteries, namely the coronary CT or coronary computed tomography, and of course the gold standard of coronary angiography and invasive study. And those what's called a functional test, whereby a priori we stabilize and will establish a parameter where we're going to follow, and based on that, we will identify whether there is any evidence of underlying lack of blood supply to the myocardium. Those are nuclear stress test, or NIBI, stress echocardiography, cardiac MRI, and PET imaging, which is not available to us. I'll start with the simplest, the cheapest, and the widest available. It's called an exercise stress treadmill. Ladies and gentlemen, this has stood the test of time. It's been around for 50 years, has been well validated, especially in middle-aged men. It's easy, has minimal risk to the patient, but implies that the patient is able to exercise and able to at least maintain a certain level of minutes on the exercise. It's staged, it's a graded approach. Every stage is 3 minutes, and there is a continuous ECG, in other words, electrocardiographic evaluation. We're looking for specific changes on the ECG, with some of them being very sensitive, like, for example, the ST segment depression at peak exercise, and some of them less sensitive. It's a fantastic test. Only if an individual is able to exercise for 5 minutes, that's equivalent perhaps for 3.5 minutes on a full Bruce exercise, the likelihood of death over a period of 6 years, as seen from a large proportion of population in Western Detroit, is quite small. Whether the patient has diabetes or no diabetes, if he or she able to exercise for 4 minutes, the likelihood of dying over a period of 6 years is slim. Is dismal, however, truly dismal, if that is not achieved. So it tells us a lot that if the patient is able to exercise, then of course it will most likely live longer. But it's a problem. The problem is that our patients are big. Our patient cannot walk. So not all of them that will be able even to get on the exercise, on the treadmill, let alone achieve the 3.5 minutes. And this has important implications, because nearly 1/3 of those kind of tests are inconclusive. In other words, either the patient was not able to exercise, or did not reach the heart rate we wanted, or was not even able to achieve the timing. This is not the kind of test that you would like to propose as a widespread test for risk stratification, because by virtue, you eliminate 1/3 of those patients eligible simply because the test will be inconclusive. But it's a good test if it's a young patient, is able to exercise, and it's good, for example, prior to non-cardiac surgery, whereby the patient has to have some degree of physical fitness. We're going to spend some time talking about coronary angiography. We're blessed at STEGH to having this technology, although we do not currently utilize it, but it's our plans to utilize them in the future. This is a fantastic imaging technique, because truly investigates all the aspects of the coronary artery wall, starting from the beginning of the remodeling towards the end of the spectrum, that is of the stenosis, in other words, of the occlusion. I'm going to start by talking about the first manifestation of atherosclerosis, which is coronary calcium. Here to your left-hand side, you see an image which is obtained just by simple radiation of the chest of a patient without any evidence of calcification, which is actually no evidence of plaque is indicated on the back. As the atherosclerosis progresses, now we start seeing some flecks of calcium within the coronary artery, and that increases the risk, which is called high risk of coronary artery disease. And finally, as time progresses, we do have significant deposits of calcium, which really testifies that the likelihood of underlying coronary artery disease is very high. I would like to underscore to this point that this kind of test is obtained without contrast. Now, if we were to administer contrast instead, we get this kind of fantastic images of the coronary artery. Here we can see the right coronary artery, nicely delineated. We can see internally the entire coronary artery in all the projections because there is no limitation of the space. Here we can see the first step of atherosclerosis, which is the remodeling of the artery. In other words, this kind of smoothen narrowing of the coronary artery with a small plaque. I'm going to show you over here a little bit better. You can see this is the right coronary artery. The contrast is the faintest color, but you can see this darker image, which represents a soft plaque. If you go a little bit below to the second arrow, you can see that the artery is nearly completely occluded. This is a soft plaque that has occluded the coronary artery, and this patient obviously will be having significant chest pain. These are unparalleled imaging capabilities, and as time goes by in elderly people, we can see more advanced atherosclerosis, whereby now the coronary arteries are stuffed with not only the soft plaques, in other words, accumulation of cholesterol, but also calcification. And you can imagine the amount of blood going through this very, very narrow segment of the coronary artery. CT of the coronary arteries are fantastic for patients with prior bypass grafting. We can see what's called a left internal mammary graft, start from the subclavian artery. This is a three-dimensional reconstruction of the heart and crosses in front, and then finally grafts, in other words, is connected to one of the arteries. And this is the saphenous graft, which takes origin from the back of the heart and then just goes forward. I was lucky enough to participate in a Scott Hart study, which for the first time we were able to show that if we use CT of the coronary arteries are our main method for discerning whether the patient does have underlying obstructive coronary artery disease, in long term, and again, this is a chest pain clinic equivalent, but using CT as the main stem of evaluation, those patients that have had the standard care discharged from the emergency department with no further investigation did not fare very well in terms of mortality, in terms of dying, in comparison to those patients have had a CT of the coronary arteries. And you might say, oh, well, because those that have had a CT of the coronary arteries ultimately end up having more tests. Actually wasn't true, because what we've seen, that's the right-hand side of your screen, there was no difference in coronary angiography between the two groups. That is the standard care discharge with no further follow-up in comparison to the group whereby was more was based on the CT and also the chest pain clinic. So those are important data. So CT of the coronary artery is good for younger people again, with ruling out coronary artery disease and perhaps before cardiac surgery in younger population. Usually we recommend that to those patients below the age of 65 years old. I'm going to the stress echocardiogram. This is an equally very user-friendly, but again, very specific technique, avails to a treadmill exercise, but associated with an ultrasound of the heart. So there are two components to it. One is the ultrasound of the heart at peak exercise, So we're looking at the thickening of the heart muscle and also the electrocardiogram. I'm going to give you an example. The upper part is, you can see what's called the left ventricle. I'm just going around, is contracting well. This is during rest, and during stress, which is normalized by speed, everything is contracting well, is quite okay. If you look below, however, this is a sick ventricle, in other words, a sick heart. During at rest, we see the part of the septum, this is the one I'm underscoring here, is not thickening very nicely, but clearly during stress, this part of the heart muscle is not moving towards the center of the image, therefore suggests the possibility of underlying obstruction of the coronary arteries. Very good test, is good for those patients, again, able to exercise, and they're able to maintain at least 4 minutes on the protocol. It's not very good for patients with arrhythmia, like atrial fibrillation, or those that have mechanical valves or any other prosthetic material within the heart, because it interferes with ultrasound. Finally, the test which is widely available to STEGH, and this test we're very, very proud to have with us, is a nuclear stress test, or MIBI. Is widely used, is based on both exercise or pharmacological, in other words, an artificial way of increasing the flow to the heart by using a specific medication called dipyridamole. Is very safe and is used with a tracer which is captured by the heart and therefore allows identification of areas whereby do not receive enough blood. So here we can see two images of two separate patients. The first one, we compare rest to stress. You can see very nicely the lower part, tracer uptake. But if you look to the upper part, it's like being eaten, as I call it, by a mouse. So in other words, that particular part of the heart does not receive any blood whatsoever. It's a high-risk patient with significant narrowing of probably one of the anterior left anterior descendant coronary artery. It's very good for pretty much everybody, but predominantly for the elderly because they're not able to exercise. In women because of the likelihood of a false positive so-called test, and those that have any kind of arrhythmia. So I have given you an overview, perhaps a little bit in a fast-forward way, of 4 important tests to evaluate the presence of coronary artery disease. Which is the best? Well, they're all of them pretty good. So this is the PROMISE study, 10,000 patients, whereby they compared either CT of the coronary arteries versus a nuclear stress test and stress echo. Over 42 months, there was no difference whatsoever in the outcome in terms of patients presenting with strokes and heart attacks, mostly between those two groups. So in other words, what it means, as long as you pick one, you should be okay, but as long as you do it. So armed with this kind of knowledge, knowing, for example, that we have done very well of reducing the risk of death, but we have done very poorly in stopping the new cases of coronary artery disease presenting late. So we had in mind to develop what's called the Chest Pain Clinic. This was based on a comprehensive risk stratification using available resources, and of course, in our case, was the nuclear stress test. We set out to have a very good initial risk stratification, a robust one. We wanted to be resource sensitive, and we want to be pragmatic. We had said that we will complete everything, I'll come back into that, within 2 to 3 weeks. Perhaps it was over optimistic, but we set up with some pillars, with some precise ways of how to do it. All of our assessment would have been done in robust screening tools, well validated, and we use expert opinion. So how did we start? Well, first of all, we needed to find a tool to risk stratify when the patient comes through to the hospital, in this kind of case, the emergency department, whether truly there is the suspicion of underlying obstructive coronary artery disease. And being also safe that this patient won't be missed if he did have significant coronary artery disease. We use this heart score. This is a very important online tool, well validated internationally, where it does take the clinical history in consideration, the changes on the electrocardiogram, and the risk factors, and gives a risk score. A low risk score, assuming that the blood test, which is the troponin, is negative, risk stratify the patient that the patient is not currently having an acute coronary event, the likes of unstable angina or a heart attack. This is crucial. We need to be safe. So what the emergency doctor will do, will go through history, ECG, electrocardiogram, risk factors, and present the risk score. Let's see how that is done. We have created this online form whereby the patient is seen at the emergency department. We use the heart score extrapolated. So therefore, as you can see, there is history, slightly suspicious, moderate suspicious, highly suspicious, and each is assigned a score number, the changes on the ECG, the risk factors, and crucially, the troponin. So a very robust way of safeguarding the patient. If, let's say, in this kind of case, the patient has slightly suspicious for underlying coronary artery disease, there are some ECG changes or scores 1, then there are some risk factors expected. I'll show you before that nearly 50% of the patients presenting with chest pain, at least in Ontario, had at least one risk factor. And finally, the troponin has to be negative. So this patient scores 3. So what's happening then? Well, the patient is safe enough, is deemed safe enough that he's not having an acute event, so can be easily discharged with further follow-up. So how that will take place? I have taken the liberty to present it in a kind of a vignette way. So the patient is having chest pain. So what usually happens? The patient goes to the emergency department. The patient is risk stratified using the heart score. This kind of scoring system I have been pointed earlier to you is indicated in the line, and then the patient is sent for risk stratification with a nuclear stress test. Because based on the clinical symptoms only, it is not sufficient enough. Once the patient completes then the nuclear stress test, and that's the key issue over here, is referred to the chest pain clinic, whereby will be seen by our colleagues. We said that all that should take place within 14 days. So let's see how we did it. We started in March 2021, at the peak of the pandemic. Despite that, we were confident enough that we can roll it out. So this data referred to up to December 2021. 217 consecutive patients have been assessed that far. Interestingly, we're able to perform the nuclear stress test within 7 days. And the patient was seen within 11 days. So we did far, far better than we had anticipated. And now the key issue. Only 7 of those patients represented back to the hospital within 3 months with chest pain, out of 270. This is a huge saving for our hospital and huge save for our resources. They were 65 years old, which is actually what one would expect, and 60% were male. Interestingly, we picked up those patients that really needed further evaluation apart from the MIBI or apart from the nuclear stress test. Because if it was positive, then we refer the patient for coronary angiography. And indeed, 30 of those patients undergone coronary angiography. In other words, 30 of those patients save them having myocardial infarction in the future with no doubt. So the key issue and the success of the chest pain clinic is not only the interdepartmental collaboration, but on the chest pain clinic in itself, because finally, that's where the patient, he will have the optimal cardiovascular risk reduction. We have risk stratified the patient that is not having acute myocardial infarction, discharge the patient, assess the patient, but as a cherry on the top, now we can deal with the risk of the rest of the risk factors. That is the cholesterol modification, the lifestyle enhancement modification, reduction of the blood pressure, and finally, the presence, pick up, if not tighten control of diabetes. Ladies and gentlemen, this has important implication because this is the key of the success over here, because this slide says it all. The more aggressive we are in reducing the risk factor for those patients that have been through this kind of system, the more we reduce the mortality. For example, if we do reduce their cholesterol, their LDL, just by instituting medical therapy or reducing the blood pressure, we're reducing the mortality, the risk of dying from coronary artery disease by a staggering 18%. That's huge. That's really huge. We reduce the risk of stroke by 42%. That's unbelievably high. So we cannot really deprive our population not offering this kind of risk assessment tool. So the way I envisage in the future, I envisage a multidisciplinary team whereby the patient remains at the center of the care, and in a radiant approach, medical practitioners, nursing staff, educators, family physician take place in order to enhance and to achieve the reduction of cardiovascular risk factors. So in a nutshell, I believe that I have given you some of the benefits of the chest pain service and of the risk stratification. I have shown you that the chest pain service, based on what we have done up to now, can robustly and safely risk stratify our patient. There is no doubt that this leads to early discharge from the emergency department and saving perhaps unnecessary admissions to the hospital. But more importantly, enhances the risk stratification to the patient with tremendous and obvious benefits in the future. Now I'm going to flip the coin because this has the benefit to the patient. But what's the benefit to the institution? Well, we have shown that early risk coronary artery stratification is feasible, even in a community hospital. Second, I think it's an important approach that a coordinated interdepartmental approach was a key component to success. We are fostering participatory collaboration. We are fostering interdepartmental collaboration agreements. Also, we have used judiciously and perhaps cost-effectively the current resources without overutilizing anything over and above, despite providing an excellent service. And finally, that's the one I like the most, is boost interdepartmental cohesiveness and spirit of collaboration, something we terribly need in these days of the pandemic. With that, I would like to thank you for your kind attention. I would like to provide the acknowledgements to these people who I would have been unable to even contemplate this kind of service. To Yolanda Mand, Teresa, David, of course, Erica from the emergency department, Phil and Walid from the internal medicine department, and of course, I cannot really forget and not thank Colt Romano and Joe Barfett for helping me out from the radiology department. Thank you very much.
Amazing. Thank you so much, Dr. Tzemos. If anyone has any questions right now, please feel free to unmute yourself or type in the chat, but we are welcoming anyone.
I would say too much.
I have a question for you, Dr. Tzemos.
Sure.
It's more around like heart disease in general. So what kinds of things can you do to lower your risk of heart disease?
To lower the risk of your heart disease, you need to know what's your overall risk. And this is the big issue. So the common risk factors are high blood pressure, diabetes, obesity, and of course, to some degree, the gender. So knowing what's your risk profile, then you can take an approach. There are, however, approaches that all of us should be following, and those are the lifestyle modification. Let me tell you something. If you were to walk 45 minutes 3 times a week, you will reduce your blood pressure by 5 millimeters of mercury, reduce your cholesterol by nearly 15%. And those will have tremendous impact to how long you're going to live. And this is something easy to achieve. I have always been an advocate of risk modification or lifestyle modification, because I've done a lot of research on salt in the past, and reducing the amount of salt as well equally reduces your risk of developing high blood pressure in the future, not reducing your blood pressure. So in a young lady like yourself, with lifestyle modification, that would be probably the best way forward. In an older man like myself, I should better be checking my blood pressure at regular intervals and my cholesterol.
Amazing. Thank you so much. Is there anyone else who would like to ask any questions about heart health?
I would.
Absolutely.
Please.
Mary.
I have many problems, but my question is on blood pressure and heartbeat. My blood pressure generally tends to be 91/67 or 71. I take 2 blood pressure pills, and my heart rate is usually 58. So my doctor doesn't like it that low, but when I reduced my telmisartan, it elevated the heartbeat, but didn't do much for the blood pressure. Sometimes it made it go up 10 points. What I want to know, is it better to keep this higher heart rate, or is a lower heart rate better?
This is a brilliant question. I can give you some background on that. Many years ago, there was an interesting study called the Pamela study. It was done in the northern part of in Italy. So what they said is the following: why don't we check the heart rate of a specific part of the population? And we're not going to ask whether they do take any medications or not. We check the heart rate, and we'll go back in 10 years' time and find out what has happened to them. So the bottom line was, the lower the heart rate, the longer they lived. Whether it was due to medication or not, it did not matter. So to answer your question, the lower the heart rate, the longer you're going to live. There's no doubt about that. And there is no, as long as you have full energy and you're working okay, walking okay, and so forth, should not constitute a problem whether your heart rate is between 50, 55, 56, 57. It doesn't really matter. My question to you is, do you take any beta blockers, any medication to reduce your heart rate?
I take the telmisartan, and the other one, it's a little pink pill for blood pressure, but that's all I take.
Okay.
And then I take one for cholesterol.
I would not worry about the heart rate. Truly, I would not worry about the heart rate. Usually what I say to my patients, I have many with fairly low heart rate, as long as you do not get any symptoms of lack of fatigue and fatigue of lack of energy, then you should be okay. I would not necessarily modify that.
I don't get dizzy at a lower heart rate. Like, her concern was that I'm going to get dizzy, I'm going to fall, and that's going to be a problem because I'm on blood thinners.
Yes, exactly. That's the point. So to answer your question on regards of the heart rate, I think you should be okay. It doesn't really matter. On regards of the blood pressure, we need to be always careful that not to be extremely aggressive, because as you correctly point out, reducing it to significant level might lead to, when you're standing up, feeling generally dizzy and therefore having falls, which in your case may increase your risk of injury.
Okay, thank you so much.
But don't touch your heart rate, it's good.
Okay.
We have a question in the chat. So, Dr. Tzemos, how does heart disease affect women differently?
Oh, that's a very good question. So, women are considered protected up to the age of menopause. Before menopause, because of the estrogen effect, it's pretty much anti-atherogenic. So, up to that time, which might be 40, 45, sometimes 50, women usually have far, far less risk in comparison to men, exactly for that reason, because of the protective effect of the estrogen. After menopause, regrettably, women are considered as men when it comes to risks. In other words, they share exactly the same risk, but they do not share the same benefit in therapy, because usually women are somewhat reluctant to seek medical advice, and this is the biggest issue. So we have two ranges. The one below menopause, women are protected by estrogen, and it's rare to see coronary artery disease. After menopause, it's exactly the same as a man.
That's very interesting.
Now you might ask me, of course, if I do take estrogens postmenopausally, would that reduce my risk of coronary artery disease? This is very controversial and has not been cross-verified in studies. Actually, we do not routinely recommend estrogen supplementation in postmenopausal women for risk stratification alone, not to reduce the risks.
Amazing. Is there anyone else who has any questions in the chat or who would like to unmute themselves? Okay, I have one more.
Please.
What are the early signs of congestive heart failure? What kind of things should people be looking for?
The first signs of heart failure, they're twofold, and they're all of them related to the excess fluid that the heart cannot pump. So one of them is shortness of breath, which characteristically will come on mild to moderate exercise. For example, going up a flight of stairs, having to stop in between, usually in a person that up to that moment has been okay, this is worrisome. But more worrisome is at nighttime. For example, you're unable to lie completely flat and getting short of breath. That suggests usually some degree of congestion. The other thing to look for is swelling of the legs around the ankles, especially towards the evening times where necessarily there will be some swelling of the ankles. Therefore, the symptoms characteristically are shortness of breath, mild to moderate exercise, let us say, as I said earlier on, unable to complete the flight of stairs, or swelling of the legs. Usually, what we see is unable to put the shoes on. They become quite tight, or there is quite marked sign from the socks, more than you'd expect in normal circumstances. If you see kind of deep seen, and usually swelling just affects up to the shin, that's probably the sign of heart failure. Those are usually the most kind of typical signs that one should be looking for. And always check the weight. So if you see, for example, you go up several pounds with no apparent reason, for example, it's not in the stomach or in that area on the belly, in other words, that's again worrisome. There is some degree of fluid retention. An echocardiogram in this kind of cases, which is the gold standard test, does not interfere with any kind of activity of the patient, nor poses any risk to the patient, is the way forward.
Thank you so much.
Pleasure. Let me just, because I can see a lot of people who might be interested, the number one killer in our society is high blood pressure. There's no doubt. If we were to reduce the blood pressure to below 130/80, the likelihood of seeing heart failure or coronary artery disease, it will be significantly reduced. The reason we have not managed to get rid of coronary artery disease and heart failure is because we have not been aggressive enough. And there is no excuse these days. We have so many medications we can try, medications that have profile of side effects similar to placebo, that it is considered criminal not being able to control the blood pressure. The second is high cholesterol. All of us growing older, living in North America, we do have some risk of developing high cholesterol. We should not be afraid of checking the cholesterol, ask for it, our family physicians and so forth. But if I had to bet money into how not to change the world, but to reduce the risk of coronary artery disease, high blood pressure is the single one that can be easily dealt, along, of course, with sugar and so forth.
Amazing. Thank you so much for sharing that, Dr. Tzemos. So if there's no more questions, I will close out the presentation. So Dr. Tzemos, thank you so much for sharing your knowledge and expertise with us today. Your presentation was very engaging and very informative. So thank you so much. If any viewers have any comments, questions, or general feedback, please feel free to email info@steghfoundation.ca. So STEGH Talks is a series of presentations that the foundation in partnership with the hospital will be hosting regularly. Make sure to keep an eye on your emails for March for another exciting presentation. So thank you so much for attending. Thanks again, Dr. Tzemos, and I hope everyone has a wonderful weekend.
Likewise, thank you very much for the invitation. Have a nice weekend.
Bye, everybody.